It's a great honor for me to speak at this conference. My name is Sagi Dain, and I'm a clinical geneticist and OBGYN specialist at Carmel Medical Center, Haifa, Israel. Today, we'll discuss the optimal genetic evaluation of pregnancies with polyhydramnios. So, as all of you surely know, polyhydramnios is actually an increased amount of amniotic fluid. It's usually measured by amniotic fluid index or by maximal vertical pocket or deep vertical pocket and can be diagnosed in about 1 to 2% of the pregnancies. Definitions of polyhydramnios vary. It can be defined by absolute measures, by percentiles, or even by subjective evaluation. However, the most common definitions of polyhydramnios are amniotic fluid index over 25 centimeters or maximal deep vertical pocket measurement of over 8 centimeters. In addition, polyhydramnios can be defined as mild, moderate, or severe according to AFI or MVP measurements. In over 70% of the cases, polyhydramnios is diagnosed in the third trimester, and in over 80%, no other sonographic anomalies are present. Polyhydramnios is associated with numerous medical conditions, including maternal diabetes, fetal anemia, viral infections, as well as various genetic disorders. Common genetic disorders associated with polyhydramnios include autosomal trisomies, myotonic dystrophy, spinal muscular atrophy, Bartter syndrome, and much more. These disorders can be diagnosed by a variety of genetic tests, including karyotyping and CMA, exome and genome sequencing, and others. So in this lecture, we'll describe the indications for invasive testing in pregnancies with polyhydramnios and the optimal methods of genetic testing in such cases. First, I want to present to you the results of our small survey in which we aim to evaluate the common practice in genetic workup of polyhydramnios. This anonymous electronic survey was distributed through the Fetal Sequencing Consortium and the Forum of Kogen, which stands for Controversies in Preconception, Preimplantation, and Prenatal Genetic Diagnosis, in February 2023. The questions we will focus on included definition of the minimal sonographic findings to recommend amniocentesis and description of the recommended genetic testing. Overall, 154 respondents participated in the survey. These included geneticists specializing in maternal fetal medicine, geneticists specializing in other fields, non-geneticists from the field of MFM, as well as genetic counselors. The answers to the question defined the minimum sonographic findings in which you would recommend amniocentesis were as follows. Over half of the respondents would recommend invasive testing only in non-isolated polyhydramnios, but not in isolated cases. 22% would also recommend amniocentesis in moderate to severe isolated polyhydramnios, and 25% in any polyhydramnios, including isolated mild cases. Differences were noted between various practitioners, as MFM specialists, whether geneticists or non-geneticists, show a higher tendency to recommend amniocentesis in more severe cases, such as in pregnancies with non-isolated polyhydramnios. On the contrary, about 50% of non-MFM specialists tended to recommend invasive testing also in mild polyhydramnios. In addition, we inquired about the recommended genetic testing in pregnancies with polyhydramnios. The majority of the respondents, 85%, recommended CMA analysis for genetic testing. In addition, 30% would recommend fetal karyotyping, 50% exome sequencing, and 13% genome sequencing. 23% would also include genetic testing for myotonic dystrophy, 11% for Prader-Willi syndrome, and 3% for spinal muscular atrophy. Significant differences were noted in some recommendations. For example, over 60% of non-MFM specialists would recommend testing for specific genetic disorders, compared to significantly lower percentage of MFM specialists. What are the statements of the professional guidelines on this issue? I hope you would be as shocked as I was in this point, since I found no guidelines referring to genetic evaluation of polyhydramnios, none. It was pretty shocking since I believe I would find plenty of guidelines referring to this common condition, as there are, for instance, for fetal growth restriction. So I believe that the results of our survey emphasize the lack of common practice guidelines regarding the genetic workup of polyhydramnios. Let's look at literature evidence on this issue. The optimal studies would be those examining the risk for abnormal genetic findings in pregnancies with polyhydramnios and comparing these risks to low-risk pregnancies. Let's begin from studies examining the yield of karyotype. This was one of my very first meta-analyses, published in 2015. We aimed to examine the risk for chromosomal aberrations in pregnancies with isolated polyhydramnios. I feel that at this point, I have to explain how I began my obsession with the genetic risks associated with the polyhydramnios. As I said earlier, the majority of polyhydramnios cases are diagnosed in the third trimester and are usually isolated. So it's not a rare event in our country that the women arrive to genetic counseling with mild isolated polyhydramnios, A5 of 24 to 25 centimeters at late pregnancy, say 35, 36 weeks. Should we recommend amniocentesis in such cases? I have to emphasize that in Israel, termination of pregnancy is allowed at any gestational age, of course, in accordance with the specific criteria, very strict after 24 weeks. And in many cases, the genetic counselors, since there is lack of any uniform guidelines on the issue, feel obliged to recommend amniocentesis. And you can only imagine how much stress and anxiety these women experience, especially since the genetic testing is performed at such late stages of the pregnancy. This is the main reason I wanted to explore this issue, to try and establish some clear and evidence-based approach. So our review included 20 studies encompassing over 1,700 pregnancies. Of these, 2% yielded abnormal chromosomal results, ranging from 0 in 9 studies and up to almost 14%. Interestingly, the abnormal findings included 5 cases of trisomy 18, which was somewhat surprising since this anomaly, this aneuploidy, is usually associated with additional sonographic findings. The analysis of 7 case control studies comparing the rate of abnormal karyotype in polyhydramnios versus control cohort indeed yielded a significantly increased risk. However, the definition of polyhydramnios varied widely between the studies. The degree of polyhydramnios was not mentioned, and it wasn't clear whether a fetal anatomical survey was performed to ensure exclusion of fetal anomalies. Similarly, many studies did not refer to various confounders, including the presence of IUGR, maternal diabetes, the results of maternal serum screening, congenital infections, isoimmunization, and multiple versus singleton pregnancies. Thus, the overall quality of evidence was rated as very low. What about the yield of chromosomal microarray analysis? One of the first studies on this issue, published in 2015, showed that abnormal microarray findings were noted in 10% of almost 500 pregnancies with isolated polyhydramnios. Interestingly, the abnormal results again included 10 cases of trisomy 18, which is supposed to be associated with additional sonographic defects. The author mentioned the absence of severe structural fetal anomalies, but what about milder sonographic findings? In addition, no referral to the degree of polyhydramnios or other confounders was noted. So in our 2021 study, we aim to analyze the risk for clinically significant microarray results in pregnancies with polyhydramnios. We wanted to address the degree of polyhydramnios, the week of diagnosis, and the presence of additional sonographic anomalies. For this study, we collected data from the Ministry of Health database and retrieved CMA results of all amniocentesis performed due to polyhydramnios in singleton pregnancies. We calculated the rates of clinically significant CMA findings, which were defined as pathogenic and likely pathogenic variants. We compared the rates of abnormal CMA to a local cohort of over 5,000 pregnancies with normal follow-up, including normal ultrasound and maternal serum screening. In this previously published controlled cohort, a baseline risk of 1.4% for clinically significant CMA findings was noted. So our study included 742 singleton pregnancies with polyhydramnios, over 80% of which were isolated. In non-isolated polyhydramnios, abnormal microarray findings were noted in 6.7% of the cases, indeed a significantly increased risk compared to the control cohort. The most prominent associated sonographic anomalies were cardiac defects, noted in 26% of the cases, as well as brain anomalies, noted in 60% of the cases. Here begins the more interesting part of our study, in which we aim to explore the effect of isolated polyhydramnios on the risk of abnormal microarray findings. Overall, in 623 pregnancies with isolated polyhydramnios, clinically significant CMA findings were noted in 3.1%. These included known syndromes such as trisomy 21 and 22q11 deletion associated with the George syndrome, as well as unique copy number variants. Overall, the relative risk for abnormal CMA results was significantly increased, being twice as high compared to pregnancies with normal ultrasound. However, this result doesn't provide us any information about the risks associated with each degree of polyhydramnios. Unfortunately, amniotic fluid index or maximal vertical pocket, allowing to define the degree of polyhydramnios, were noted only in 276 pregnancies. 27 pregnancies had borderline polyhydramnios, A5 between 24 to 25 centimeters, and CMA analysis was normal in all these cases. Mild polyhydramnios was noted in 158 pregnancies. Abnormal microarray was noted in 4 of these pregnancies, yielding a risk of 2.5%. You can see here that this risk was not significantly increased compared to the baseline 1.4 risk for abnormal CMA results in pregnancies with normal ultrasound. Of the 68 pregnancies with moderate polyhydramnios, 5.9% were diagnosed with abnormal microarray findings. This risk indeed was significantly increased compared to the baseline risk. Lastly, we had only 23 pregnancies with severe polyhydramnios. The risk here was not significantly increased. However, no conclusions can be made based on such low numbers. So to conclude by this point, we showed that moderate isolated polyhydramnios is indeed associated with increased risk for abnormal microarray results, while in the cohort of 158 pregnancies with mild polyhydramnios, no significantly increased risk was noted. In addition, we tried to examine the effect of the percentile of polyhydramnios on the risk of abnormal microarray results. This was possible to calculate only in 247 pregnancies. For this analysis, we relied on the table of Moore et al. This is a very useful table to establish percentiles, although it's a 1990 study with small numbers of pregnancies for most weeks. You can see that that the cutoff limit for late onset polyhydramnios is over 27 centimeters for most weeks, higher than the accepted 22 to 25 centimeter cutoff to define mild polyhydramnios. So the risk for abnormal microarray was not significantly increased in pregnancies with polyhydramnios measures lower than the 97.5 percentile for the specific week. Over this percentile, a significantly increased risk was noted in the cohort of 182 pregnancies. When examining the effects of the timing of the diagnosis noted in 486 pregnancies, the risk for abnormal microarray was significantly increased in polyhydramnios diagnosed between 28 to 34 weeks, okay, but not in earlier or later diagnosis. So to conclude, the risk for abnormal microarray results was increased in pregnancies with moderate polyhydramnios or with polyhydramnios over 97.5 centile, as well as in cases diagnosed between 28 to 34 weeks. Our study, although one of the first to refer to polyhydramnios degrees, has multiple limitations. It was retrospective. We did not have data regarding maternal diabetes or viral infections. Data collection was not uniform. We did not have data regarding later prenatal or postnatal follow-up. And of course, some of the subgroups were very small. An additional recent study published in 2024 also described microarray results in 600 pregnancies with polyhydramnios. Over half of these were non-isolated. The authors reported a pretty similar percentage of abnormal microarray results in isolated polyhydramnios, 2.3%, and in our study it was 3.1%. Interestingly, of the 6 abnormal cases in this group, 2 were triple X, not associated with any known severe clinical consequences, and 1 was a case of 17p12 deletion associated with hereditary neuropathy with liability to pressure pulses, a late onset and rather mild disorder. We do not usually include this disorder in our calculations. Finally, let's talk about the yield of exome sequencing in polyhydramnios. This is a very nice recent retrospective study describing the postnatal evaluation up to 1 year of 73 pregnancies with idiopathic polyhydramnios. All pregnancies were with normal ultrasound, normal karyotype and CMA, and negative for some congenital infections. Genetic disorders were noted in 8 cases, almost 11% of these pregnancies, except for 1 case of 22q deletion. 7 cases were detectable only by exome sequencing. These included 3 rasopathies, 1 Noonan syndrome, and 2 cardiofacial cutaneous syndromes, which are known to be associated with polyhydramnios. Additional 10 conditions were also severe, but had no identified genetic basis. Intriguingly, although over 70% of polyhydramnios cases in this study were defined as mild, amnio reduction was performed in over 58% of the cases. So it's interesting what was the criteria for amnio reduction in these pregnancies, or the definition of mild polyhydramnios. This is another recent study describing the yield of prenatal CMA and exome sequencing in 94 pregnancies, singleton pregnancies with isolated polyhydramnios. Overall, 7 abnormal genetic results were noted, 7.4%. This included 4 cases diagnosed by CMA. You can see here 2 cases of trisomy 21, 1 DiGeorge syndrome, and 1 microdeletion associated with Prader-Willis syndrome. 3 cases were diagnosed by exome, including Bartter syndrome, and 2 de novo autosomal dominant genetic disorders. So it seems that exome sequencing has additional value over CMA testing. However, further studies are needed to explore this point. What about additional genetic mechanisms not necessarily detected by both CMA and exome? We have here medium-sized copy number variants, uniparental disomy, disorders caused by trinucleotide repeats expansion, and others. Actually, the 3 genetic disorders known to be associated with polyhydramnios, spinal muscular atrophy, UPD-15 of Prader-Willis syndrome, and myotonic dystrophy are usually not detected by CMA or exome. I have found only one study from 1998 referring to the yield of genetic testing for myotonic dystrophy in 41 pregnancies with polyhydramnios. Following exclusion of diabetes mellitus, the hydrops, or fetal anomalies, 4 cases with myotonic dystrophy were noticed. That is about 10% of the pregnancies. However, in 3 of these 4 pregnancies, a family history of myotonic dystrophy was present, and in all, an abnormal posturing of the extremities or clubfoot were noted. So I'm not sure we can define it as isolated polyhydramnios. However, this study emphasizes the importance of sonographic evaluation for signs of fetal hypotonia, as well as detailed family history and parental examination for signs of myotonic dystrophy. I did not find any studies specifically examining the yield of spinal muscular atrophy testing, as well as methylation studies for UPD-15 associated with Prader-Willis syndromes. Similarly, I did not find any studies describing the yield of genome testing in pregnancies with polyhydramnios. I'll try to conclude, although it seems that this lecture only took us back to the beginning. Polyhydramnios does appear to somewhat increase the risk of genetic disorders. However, the existing evidence is limited, especially for mild polyhydramnios, and is potentially influenced by many confounders. The first recommendation would be that pregnancies with polyhydramnios should undergo detailed sonographic evaluation to rule out associated sonographic anomalies, including signs of fetal hypotonia, as well as cardiac and brain defects. Genetic testing should be recommended for pregnancies with non-isolated or moderate to severe polyhydramnios. Parental examination and detailed family history should evaluate for signs and symptoms of myotonic dystrophy. And we should ensure parental CMA testing in the scope for SMA testing in the scope of pre-gestational population screening. And finally, as it is usually stated in the end of any lecture, further studies are urgently needed to explore the yield of genetic testing in polyhydramnios, taking into consideration numerous confounders. I thank you for your attention and will be happy to answer some questions.